All right, so our first session of the morning, as you can see, is titled Understanding Your Lymphoma Diagnosis. As part of this, I think there are a couple of people that become very important in helping someone sort this out. The person that you see in the clinic that helps get all of the testing done and does the initial assessment, as well as the pathologist that is responsible for the tissue when it comes into the lab. And so luckily we have both sides of that equation available today. So again, Shannon's already been introduced, and so Shannon, we're very lucky to have her working at Princess Margaret in our rapid diagnosis clinic. And another good friend and colleague, Rashmi Goswami there, who's a pathologist previously at Princess Margaret, now up at Sunnybrook. And so they will walk you through some of the key issues behind understanding your lymphoma diagnosis. Shannon.
Thank you. I just want to say thank you so much to Christina for sharing your story. It was very touching. So we're going to, unfortunately, Christina's, what caught me most about her story was the initial sort of diagnosis and the comments around, people dismissing her and how it took so long for her to get a diagnosis of Hodgkin's lymphoma. And this is actually a very common occurrence, and this is where patients tell me a lot of the time, why did it take so long? So Dr. Goswami and I are going to spend a little bit of time trying to explain why sometimes the diagnosis of lymphoma can be so difficult and prolonged in some cases. Excuse me. Okay, so just to start off, just as a review, I'm sure most of you know all of this already, but lymphomas are a heterogeneous group of cancers, and what that means is basically they're not all considered to be one entity. There's varying different presentations and forms and subtypes of lymphoma. They develop from lymphocytes, they develop from B lymphocytes, T lymphocytes, and natural killer cells. Basically, malignant cells accumulate in the lymph nodes and other extranodal sites. So extranodal meaning outside the lymph node. That might be the spleen, the liver, other areas in the brain, for example, producing tumor masses and eventual organ dysfunction if not treated. So this is a very complicated slide, which for those of you who did not take anatomy and physiology in university, you may not know this, but basically it's how the blood cells develop. So all of our blood cells are sort of born inside of our bone marrow, which is that spongy tissue deep inside of our big bones, like the hip bones. Okay, this is where all cells are produced: red cells, white blood cells, and platelets. So on the myeloid stem cell line, which is on the left side, this is where we produce more of our red cells and platelets. But on the lymphoid stem cell line is where lymphoma develops. So lymphomas arise from the proliferation or the dividing of cells at varying stages of development and differentiation. So depending on how mature the cell is or how long it's had a chance to grow, depends on how quickly cells are dividing and which subtype of disease we're looking at. So for example, an acute lymphoblastic lymphoma or a Burkitt's lymphoma, these are types of lymphoma that are very immature type of cells that are growing and sort of can occur at the bone marrow site or just outside the bone marrow. Whereas smaller cells tend to be things like small cell lymphoma, CLL, for example. So this is just a very quick and very simplified version of lymphoma, but we often think about lymphoma in terms of non-Hodgkin's lymphoma, which comprises the majority of lymphomas, about 90% of them, and Hodgkin's lymphoma, which is about 10%. Non-Hodgkin's lymphoma can then be subdivided into B-cell lymphomas, which are the majority, and then T-cell lymphomas. So then we think about B-cell lymphomas, and they're also subdivided into large cell lymphomas, or sort of fast-growing aggressive type lymphomas, or small cell lymphomas, which are more slow-growing indolent types of lymphomas. So So this is a slide from the most recent Canadian cancer statistics that were published just about a month ago, actually. So you can see here, these are the projected Canadian cancer cases for 2019. You can see that there's a slightly more incidence of cancer among males, but non-Hodgkin's lymphoma is about the 5th or 6th most common cancer. So not the top 3, okay, certainly not prostate, breast cancer, lung cancer, these are the most common. But the relevance of that is that lymphoma is the largest survivor population in North America, other than breast cancer. Although half of lymphomas have incurable cancers, they do have a long natural history. So what I mean by that is follicular lymphoma example, the median overall survival is greater than 15 years, and I think it's actually up to 18 years now. So how does lymphoma present? Or, I work in the clinic at Princess Margaret where I see patients that are referred for any sort of suspicions of lymphoma, and I help diagnose them and get them through into until we know exactly what's going on. So when I see patients, I'm usually seeing them for, lymphadenopathy, okay, enlarged lymph nodes, most commonly palpable lymph nodes in the neck, the axilla, the groin. Sometimes lymph nodes can be across the mediastinum, which is the area in between your lungs, or anywhere in the intra-abdominal area. Sometimes, in a small proportion of patients, actually, you can develop B symptoms, such as weight loss, fevers, or night sweats. Anywhere where lymph nodes can be enlarged, such as in Christina's case, she talked about having chest discomfort. She likely had a mass across her mediastinum that was pressing on her lungs and causing her to have some discomfort. So anywhere lymph nodes can be enlarged can cause pain in these type of organs. The spleen can be enlarged. The spleen is actually a really important organ in our body that's responsible for filtering blood cells. It's also a big part of lymphoma and often is involved. So if the spleen is enlarged, that's another big indicator. And sometimes changes in blood counts. Christina talked about being anemic as well. And being anemic can mean that there is bone marrow involvement with the disease, but it also can mean just an inflammatory process going on that's causing you to have low red blood cells and not feel so well. This is just a slide to remind you of where the lymph node regions are, and this is how we sort of look at lymphoma and how we stage lymphoma, but this is where you could have possibly all different lymph node enlargement. I won't spend too much time on that. These are some of the characteristics of large and small cell lymphomas. So with a large cell lymphoma, we think about rapid growth, okay? Patients most often have symptoms related to that. And we know that if left untreated, these types of lymphoma can be fatal. Whereas small cell lymphomas, often patients are very asymptomatic. They have noticed a lump in their neck for several years. It's been sort of coming and going. They don't feel unwell in relation to it. It's a very slow-growing, indolent type process. Long natural disease history is possible. So these are the sort of the things when patients come to my clinic that I'm starting to think about. Do I think this patient has lymphoma? Because there's a lot of other reasons that lymph node enlargement can happen, and what type of lymphoma, because that will dictate how quickly I need to sort of get on to a diagnosis. But wait, lymphoma can be a diagnostic challenge. Lymph node enlargement is common, okay, affecting all ages. We think about lymph nodes can be enlarged for a variety of reasons, the most common being infection, things like mononucleosis or a throat infection, anything like that can cause a lymph node to enlarge. We also think about rheumatologic conditions such as lupus or rheumatoid arthritis that can cause lymph node enlargement. Cancer is actually down on the list of how common. This is a sort of paper that was presented in 2000 in England, where they assessed the average family doctor who has a roster of about 2,000 patients. They might see a diagnosis of lung cancer 1 to 2 times a year. They might see a breast cancer patient once a year. But lymphoma, they might see one every 4 years. And actually, Hodgkin's lymphoma, they might see one in their practice every 20 years. So you can imagine that when you show up to your family doctor with an enlarged lymph node, their first concern is looking at other reasons. It's not that common to see lymphoma in their practice. Okay, so ruling out things like infections or inflammatory type responses are probably their priority. But at the same time, sort of knowing what are the big red flags to sort of say, is this lymphoma? And Christina, sorry to use this as an ongoing example, but clearly she had a lot of red flags going on that were chest discomfort and not feeling well. So then, when we think that this is lymphoma, we need to get on to a diagnosis. And so to obtain a diagnosis of lymphoma, we need an appropriate lymph node or other tissue biopsy for review by an experienced hematopathologist. So ideally, the largest and most suspicious and most accessible lymph node is targeted for biopsy. I will tell you that we all have normal lymph nodes in our groin area. They can be slightly enlarged, particularly in the summer months when we're wearing flip-flops or sandals and we're being exposed to sort of, sort of conditions in the summer. So that's actually a normal finding to have 1 to 2 centimeter lymph nodes in your groin. But lymph nodes sort of up and above, where in your neck, in your lower part of your neck, these are definitely abnormal. Okay, so. When we think about whether something's suspicious or not, we think about the size of a lymph node, how big it is, the location of the lymph node, okay? And then we want to think about where the most accessible spot is to biopsy. So I just want to introduce you to James. James is, I'm going to use him as an example here. He's a 21-year-old young man, just finishing his 3rd year of political science at University of Toronto. In April, he developed mid-abdominal pain and lower back discomfort when studying for his exams. This gradually progressed until June, when the pain became so severe. He went to the emergency room, where he was admitted for a number of investigations. James had some blood work done, which showed he had a hemoglobin that was a little bit on the low side, measuring 101. For a man, a normal hemoglobin is about 140. The rest of his sort of blood counts were normal. He had CT scans of his chest and his abdomen, and this showed some enlarged mediastinal lymph nodes. The largest measured up to about 4 centimeters across his anterior mediastinal chest. He also had an enlarged spleen. Normal spleen size is about 13 centimeters, so this is just slightly enlarged. And he had some intra-abdominal lymph nodes, with the largest measuring 4 centimeters, sort of in and around the mesenteric part of his abdomen. He also underwent, while he was admitted, he went under an upper endoscopy. So when you're admitted, and you have anemia in a young man who's 21, they're not really sure why, we're looking for signs for bleeding. So they would have had a scope put down into his stomach to check for signs of bleeding, and that was normal. So then what did James do? I'm going to tell you that there's a couple of different biopsies in how we diagnose lymphoma. So the first one is called a fine needle aspirate, an FNA. And this is where cells are collected using a needle, okay? This allows some opportunity to look at whether there's a malignant process going on, but it's certainly not a diagnostic process for lymphoma. It's less able to rule in and out a lymphoma process, but it can be helpful in determining next steps. Sometimes the pathologist can do something called immunohistochemistry, which Dr. Goswami is going to explain to you a little bit further, but basically there's proteins on cells of lymphoma cells where if you if they come and go during different stages of maturation. So they can run stains on these cells to see which highlights and how sort of developed that cell is, and that helps with diagnostic process. So this is just one type of biopsy, which really isn't helpful in our patient's case. It's going to tell us whether we think this guy has lymphoma, but probably not a full diagnosis. Then there's something called a core biopsy. These are small cores of tissue where they're collected using a needle. You can see in my diagram there, that's actually a real core biopsy sample of a patient that I had. It's kind of sort of as thin as the end of a pen, okay? Not very big at all, actually. It's more informative than a fine needle aspirate, less invasive than a surgical procedure, because this can be done in our interventional radiology department under image guidance. Probably most of you have had this procedure before. Yes. They use either a CT scan or an ultrasound machine to find the lymph node area, and they put in a needle and take a sample of the lymph node. Unfortunately, this isn't reflective of the entire lymph node. If you picture a lymph node being around 4 centimeters and they go in and they take one core sample, that's actually not, it doesn't tell us what's going on with the entire lymph node. And the pathologists often have a lot of difficulty assessing the architecture and making a diagnosis based on a core biopsy. So James had a CT-guided core biopsy. They had 2 small core samples were obtained, and unfortunately, the pathology report was inconclusive. Unfortunately, these core biopsies that he had were without recognizable lymph node architecture, and they couldn't run these sort of immunohistochemistry stains because they didn't have sufficient lymphocytes for evaluation, if that makes sense. I'm going to show you, this is a CT scan of an abdomen. So basically, a CT scan is looking at, picture as the CT scan sort of moves down your body like this, okay? On the very far left there, you can see that's this sort of big white area is the liver. These bottom 2 sort of like round sort of white things are called the kidneys. You can see the gallbladder on the top left. You can see the loops of bowel, okay? And then you can see these 2 lymph node masses kind of in red there. The top one is a mesenteric nodal mass, and then the bottom is a retroperitoneal, or sort of meaning towards the back of the peritoneum nodal mass. So I just wanted to show you this slide because it can be a bit difficult to obtain a core biopsy sample based on the location of those lymph nodes. It's not as simple as just going in and taking a good biopsy sample. When you're going after these mesenteric nodes, you have to sort of get in and go through the bowel and that kind of thing. The needle would have to sort of go in and sort of maneuver around some of these organs. Going in through the retroperitoneal mass is often a little bit easier, but they do go through the back, and they have to make sure they avoid the kidneys and other big organs like that. So I just wanted to show you that to explain why sometimes getting in there to get a good biopsy sample is difficult. So back to James. Unfortunately, after he got his undiagnostic pathology, he started getting sicker. He developed daily fevers, drenching night sweats. His energy level was low. He had lost approximately 20 pounds. At this point, when I actually saw him in my clinic, I had found some new lumps in his neck. It's actually the right side of his his right side of his lower neck. And these were actually quite enlarged, 3 to 4 centimeters in size. At that point, I referred him to a surgeon, and he went on to have what we call an excisional lymph node biopsy, where he had a surgical removal of the entire lymph node. And then he was diagnosed with classical Hodgkin lymphoma. So this is a paper that was published in 2014, and these are our guidelines that we follow in terms of diagnosing lymphoma. We need an excisional biopsy as much as possible to get a diagnosis of lymphoma, and Dr. Goswami is going to explain a little bit more about why that's so important, but it allows the pathologist to look at the architecture and have a lot of tissue to run their extra staining and stuff like that. A core needle biopsy is possible, to get a diagnosis sometimes when we don't have access to a surgical biopsy sample. This is an excisional biopsy where they go into the operating room. It usually takes only about an hour. It's a quick procedure, and this allows adequate tissue to run all of these tests. Although this option is not the best for everyone, it does require going into the operating room under a general anesthetic for most cases, and it may not be best for everyone. So how long can this take? I think that we looked at our numbers at Princess Margaret prior to 2015, and we looked at, for any patients who came into the University Health Network, whether that might be Toronto General Hospital or Princess Margaret, their entry into visit to a diagnosis of lymphoma was 28 days on a median, so an average size, or an average day. And then their entry visit into the time of when they started treatment was about 48 days. We decided this wasn't good enough. We also saw that in the Royal Marsden Clinic in the United Kingdom, they were looking at a diagnosis of lymphoma ranging from 21 to 24 days, and that's where they actually developed a lymph node diagnostic clinic. So still not great, but a little bit better than what we were doing. I think those numbers are a little bit wrong, but anyways. So a little bit better than what we were doing, but still not great. So anyways, I think prior to 2015, we were doing this sort of thing. So we developed this lymphoma sort of rapid diagnosis clinic because we understand that the diagnosis of lymphoma is actually quite difficult. We really need good pathology assessment, okay, good pathology samples for assessment, and we need to get good imaging to sort of assess this. And it's really sort of a big multidisciplinary approach. So we developed a lymph node rapid diagnosis clinic at Princess Margaret, and the idea is to help patients like Christina get onto a diagnosis in a timely manner. And I think I haven't shown you any of the data, but we did do a lot better since then, and we've cut down our times to diagnosis to about 14 days. So I'll leave that for now, because Dr. Goswami is going to talk to you about what happens when she gets the tissue. So thank you.
Okay, so hi, I'm Dr. Goswami, and as John mentioned before, I used to work at Princess Margaret. I'm now at Sunnybrook. So yeah, I'd like to talk to you about what happens after you get your biopsy. So this is kind of a peek behind the curtain because nobody really talks about what happens in pathology. Yeah, so I'm just going to give you a little bit of an overview. So the first thing is that so as Shannon mentioned, you can get numbers of different types of biopsies. You can get fine needle aspirations or an FNA. You can get cores, or you can get excisional biopsies. Basically what's common to all of them is that those specimens actually need to be preserved. The minute they come out of your body, they start to degrade. And if you want to do additional testing on your tissue, we need to make sure that the cells that are collected are actually kept kind of intact so that we can do more testing on them. So what we do is we put them into chemical solutions called fixatives, and then and this can take some time. So usually, like if we were going to do it very rapidly, I think it can be done within 6 to 8 hours. But ideally, you should fix them for overnight. That preserves all of the proteins and all of the material that we can do additional testing on. If you rush the process, sometimes it compromises what the cells look like, and it can make my life more difficult because then it's difficult to tell exactly how the cells differ from normal. So this kind of gives you a little bit of an idea of what happens behind the scenes. So your tissue, so if this was an excisional biopsy or a core biopsy, your tissue comes back to the lab, and then in that first panel you can see that there are, excisional biopsy, we cut it up into very thin sections. That allows the fixative to actually permeate through the tissue and helps preserve the tissue better, because if you have a really thick piece of tissue, then it takes a long time for the fixative to go through. So then in the second panel, you can see they're put into cassettes, and that also allows more fixative to go through. So the third panel is just somebody putting tissue into the cassettes. So then the next thing that happens is after the tissue is fixed, it needs to go undergo what we call processing, and this is because. So as you all know, or if you learned in science class, we're mostly water. So basically, like, we're 3/4 water. And in order to keep tissues for long, long periods of time. And actually, in order to solidify the tissue so that we can cut sections from it, as I'll explain to you later, you need to convert all that water into kind of a form that allows for us to infiltrate it with wax. So you know how oil and water don't mix? Because of that, we need to actually treat the tissue even more so that the wax can actually infiltrate the tissue. And so we treat it with a number of different alcohols and other chemicals, and then that allows us to eventually put wax through the tissue, and then you get what's called a tissue block. So in the picture that's here, you can see that there's a little piece of tissue that's embedded into a wax block. And then this actually allows us to keep the tissue at room temperature for decades. And it's basically how most people in pathology labs preserve tissue. And so your core biopsies, your excisional biopsies can be kept in the lab for quite a while for additional testing that we can do immediately or, you know, several years down the line if needed. And so this is the reason that we actually want tissue into paraffin blocks. So in the first panel, you can see, let's see if I can. Yeah. So in this first panel, you can see this is the tissue block here, and this is a blade. And so basically what happens is we, so a histology tech will take that block and bring it across that blade several times. And so that cuts the tissue into very, very thin sections, which we can then stain with various other chemical solutions, and then that allows us to actually look at the cells and see whether or not you have cancer versus a totally normal lymph node. And so in that first panel, you can see that histology tech is cutting sections of tissue, and he or she is actually producing a ribbon of tissue sections. In the second panel, you can see that you can see these ribbons are being laid out, and then eventually what happens is the histology tech will put a slide on top of these tissue sections, and then they're stained, and then they come to me. So then this basically this is the type of stainer that we use, and what happens is those slides are put through various stains, and then that allows us to then look at the cells and try to figure out whether or not they look completely normal or abnormal. So then, how is this diagnosis made? So sometimes I talk to people who aren't really involved in the medical field, and they ask me what I do, and I say I'm a pathologist, and then they say, oh, what does a pathologist do? And I tell them, like, I look at tissues that come out of people's bodies, and then I determine whether or not they have cancer or not. And then they tell me something like, oh, I didn't realize that there was a person involved behind that. I usually think, I thought that, the tissue came out and then it went into like some sort of like black box, and then like a computer printout comes out, and then I get my diagnosis. And that would be lovely, but that's not really how it's done. So I'm that black box, and people like me are that black box. So basically what happens is your tissue comes out, and then it goes through all that processing that I talked about, and then it comes to a pathologist. And a pathologist is a physician, actually, who's had just as much training as all of the other clinicians that you see in the clinic. But their specialty is in looking at tissues in order to figure out whether or not they have cancer. And so it's usually like 13 plus years of training, and some people actually undergo subspecialty training specifically just to look at lymphomas. And so basically what we all do is we look at the tissue through a microscope, and then we determine, is this cancer, is it not? And often it's kind of hard to tell, and we have to do additional testing in order to figure out whether or not you have cancer. So I'm going to show you a few slides that'll just explain what we see and why it can be sometimes hard to tell. So this is what a normal lymph node looks like. So basically what you have is these light and dark areas. that are called, so the light areas are called lymphoid follicles or germinal centers. And then the germinal centers, if you can see, anyway, so the germinal centers basically are like the light areas within the lymph node, and inside, a lot of them have very large cells, and outside are more small lymphocytes. So just keep that in your mind. That's what a normal lymph node looks like. So the first case I'm going to show you is from a patient who was about 26 years old, and she had come in with enlarging lymph nodes under her arm. And so basically, luckily, she got an excisional biopsy. She didn't go through like multiple rounds of like, FNAs and core biopsies. Like they went right for an excisional. And then so as you can see in that first panel, the lymph node doesn't look like a normal node. Like you're not really seeing those big circle-like patches with like light and dark. It's kind of looking a bit more even. And then in the red circles in the next panel, those are very large cells that to me as a pathologist are not normal and are suspicious for lymphoma. So I'm going to show you the next slide. So this was from a 68-year-old man, and in the first slide there are these small kind of circle areas that have light and dark, and so you may be thinking, oh, well, that kind of looks normal. But the thing is that those light areas are smaller than normal, and in between them, there's like a lot of cells, and that's not normal. And then in the next panel, you can see in the red circles that there are also large cells. So I just wanted to show you these two cases because these two patients both have these odd cells, which, yeah, they look like cancer, but these two people have two different types of lymphoma. So this first case, this 26-year-old, she actually has Hodgkin lymphoma. And then in the second case, this person, the large cells are abnormal, but the small cells are abnormal too. And this person actually has T-cell lymphoma. And those are totally two different types of lymphoma with totally two different types of treatments. So you can see how it can be difficult to tease apart. And often we do additional testing that we interpret in order to come to a full diagnosis. So some of the additional testing that we do, I'm just going to go through a few. So one of them is flow cytometry. And flow cytometry is a way to look at proteins that are expressed on cells and figure out whether or not they're normal or whether or not they're malignant or cancerous. So in this first panel, you can see there are dots on a plot, and those dots tell me that on the one axis, called kappa, and on the other axis called lambda, like if you see dots on either side, then I'm seeing a population of cells that contain kappa and cells that contain lambda. So those are two different types of protein. And in normal people, or people who have normal lymph nodes, then those basically all of the lymphocytes, the B lymphocytes that you have will either express kappa or lambda in usually like equal proportions or at least a 2-to-1 ratio. So but in the next panel you can see there's like a big blue kind of mass of cells. So each point is a cell, and so because there's you can see a lot of blue, that tells me that there's more kappa in this patient's tissue than lambda. There's almost nothing. And so that's not normal. So that gives me a clue that, hey, there's actually B cells that are only producing one type of protein, and it's most likely a cancerous clone. And then in the next panel, you can see that on the one axis, there's CD19, and then on the other axis is CD10. And that blue area is, those are cells that express both CD19 and CD10. And you can see that in normal cells too, but because there are so many in this patient's tissue, that's abnormal. And so that tells me that this person has a CD10 expressing B-cell lymphoma. So flow cytometry is great. You can look at up to, 10 proteins at once on a cell or even more. But the thing is you need fresh tissue, and people need to tell you up front that, hey, I think this patient might have a lymphoma. Can you keep some fresh tissue in order for flow cytometry? And so So you need to keep that in mind. So sometimes if somebody accidentally fixes that tissue, so fixing tissue doesn't let me do flow cytometry on it. So if somebody wasn't suspecting lymphoma and then, the tissue ends up getting put in that preservative that I was talking about, then, these options are unavailable to me. So then another test that we can do is called immunohistochemistry. I think Shannon alluded to it earlier. So immunohistochemistry kind of does the same thing as flow cytometry, but only looking at proteins one at a time. And it's done on those tissue sections that I was talking about. So here, this is a CD20 stain, and basically what happens is if a cell is expressing CD20, then I can put a stain on it to see whether or not so basically what happens is we have color-tagged antibodies that recognize CD20, and then when we put them on a tissue section, there's a chemical reaction and you get brown deposits on the tissue. And then that tells me, when I look at it, that these cells are expressing CD20. And this is important because CD20 is actually one of those proteins that can be targeted with therapy. So if any of you have received rituximab as part of your chemotherapy regimen, it was because your cells express CD20, and rituximab actually can target CD20. We can also look at nucleic acid. So I don't know if you can tell, but in that second panel, there are little blue dots there. So there, what we're seeing is that there's a color deposit when there's a reaction between the probe that we've put down for RNA, which is a type of nucleic acid that Epstein-Barr virus produces. So when I look at this tissue and I see these blue dots, I can say, hey, this patient actually has, active Epstein-Barr virus in these cells, and that can actually be a sign of cancers that are caused by Epstein-Barr. So these are all sorts of tests that we can do on your tissue in order to come to a better diagnosis. The other thing that we can do is molecular analysis. So here, this is a clonality test showing you the differences between normal and lymphoma. And so this is a DNA test that we can do in order to figure out cancer versus not. And then other types of testing include cytogenetic analysis, which is another type of DNA test where we probe for certain DNA sequences on the tissue. And different colors will tell us whether or not we have abnormal expression of DNA. The other thing that we can do is also gene expression analysis. So sometimes different cancers will express genes in different levels, and that can tell us whether or not you have one type of, or one subtype of cancer over another, and that can give us some information about prognosis. So this is just to let you know that these are all of the types of lymphoma that we're thinking about when we're looking at your tissue. And this is the reason that we need to do all that additional testing in order to pinpoint exactly which type of lymphoma that you have. And so it's quite complicated. And why does it matter? Like, why do you need to know the exact type? Like, can't you kind of get like a preliminary, broadish diagnosis? And the reason is that you need an accurate diagnosis in order for your hematologist or oncologist to provide you with a proper therapy for your type of lymphoma. And sometimes, as I mentioned before, the findings that we see on pathology can actually point to different types of targeted therapy that you may benefit from. So for example, CD20, if your lymphoma is expressing CD20, then you can be put onto rituximab. CD30 will allow you to be put onto a therapy known as brentuximab, and so on. And then an accurate diagnosis and the results on ancillary testing, such as like genetic testing or the types of DNA testing that I was talking about, can help you access different clinical trials if you have the accurate diagnosis. Oops, sorry. So some of the issues that can arise during your diagnosis, which Shannon alluded to before as well. So sometimes the specimens that we get aren't necessarily diagnostic. So here in the panel, you can see, so I want you to go back in your mind to think about that normal lymph node. It was kind of like it was very blue. Those were all lymphocytes in that lymph node. But this is looking a little bit, it's very pink. And you can see kind of these like white areas in that. So all those white areas are fat. And that pink area, that's just collagen. It's just collagen fibrosis. There's very few lymphocytes in here, and if I was to look at this would be non-diagnostic. So basically what would happen is, what had happened is, when they did the core biopsy, they actually missed the lymph node. They got an area that just had fat and collagen. And so what does this mean? So this means that this patient, unfortunately, has to undergo another biopsy if the hematologist oncologist thinks that this person has lymphoma. And so, as Shannon mentioned before, excisional biopsy is best. And so unfortunately, if you have a fine needle aspirate and it's an undiagnostic, that moves you to a core and or an excisional biopsy. And so that can add time to the journey towards your diagnosis. And then the other problem is that, well, maybe they did get, maybe they did get some lymphoma on that core, but, I told you that I needed all of that other testing in order to come to an accurate diagnosis. And if you don't get enough tissue, then you can't do all of that ancillary testing. And so sometimes that can be a problem. So we can give you sort of a preliminary or partial diagnosis, but then, if you wanted something more accurate, you may need to get more tissue in order to get the additional genetic testing that you might need. Another issue that can arise is that, at your hospital, maybe they don't do those other types of testing. And so, what will happen then is that the specimen comes to the lab, and then maybe the morphologic or basically the tissue diagnosis that pathologists do under the microscope can be done, the immunohistochemistry can be done, but then, let's say the cytogenetic analysis actually has to be sent out to another lab, and then that can add a delay because the tissue is then sent to a different lab in order to undergo the testing, and then it comes back, and then, the report may take, a week or two longer. And then finally, the diagnosis is complicated. Like you saw that list of all those different lymphomas, and sometimes they can look very similar to one another, and we may, even with our expertise, we may actually need to converse with one another to say, hey, I did this and I did all of this testing. It's possible that it's like one of 3 different types of lymphoma. What do you think? And then sometimes, your biopsy may need to be sent to another hospital or another center where they see maybe more types of those types of lymphomas, and then they can come back with a diagnosis. So then that can add a delay to your diagnosis. So in summary, making a diagnosis of lymphoma is quite a complicated procedure, and it can sometimes be difficult and prolonged. And the reasons are several-fold. So one of them is that, as Shannon mentioned, the incidence is pretty low in the general population. So somebody who presents to their family doctor who has a big lymph node, while it may not necessarily be lymphoma, and it may not be the first thing that your family doctor thinks about. And then the other thing I wanted to mention is that, there's different types of sampling, and that so although an excisional is best in all scenarios, sometimes you can't get to the affected lymph node because it's near a vessel, or it's in an inaccessible site, and so we may need to make do with like an FNA or a core, but just keep in mind that we know that this is a very important diagnosis, and we do everything that we can in order to get you your accurate diagnosis. And then also there's a variety of different lymphomas, and that it's not a black box, it's not a computer printout, it's a person who's looking at your slides to come to that diagnosis, and that we use multiple techniques in order to help come to that diagnosis. And that finally, establishing the right diagnosis is critical in helping you and your doctor in determining the proper treatment options for you. So that's it, and we're open for questions. Did you want to come up? Sure.
Who decides what type of cancer you're staining for when you do get those slides? Is that the surgeon, or is that you as the pathologist? who makes that decision once that slide gets to you?
Yeah. So as I said, we've had a lot of different training. So I'm just going to tell you about the type of training that I've had. So I went through med school, and then I went through a residency. It's called anatomic pathology. And so anatomic pathology kind of gives me a background into looking at basically all the different cancers in your body. And then after that, I did subspecialty training in, like, specifically in lymphoma pathology. So when I look at, basically when a tissue comes to me and I look at it, I can tell whether or not this is like lymphoma versus another type of cancer. And so based on just looking at the cells, we're the ones who actually we're the ones who actually figure out whether or not it needs additional testing for whichever different type of cancer.
So the pathologist is the one who makes that decision when they get the sample, they determine it all.
Yeah.
So if something was missed and it had to be restained a year later, that was the pathologist that made that error?
So basically, well, no, so that's the other thing. So like things change all the time, right? And so maybe at that time it's possible that everything was done for how much they knew about that entity, and then later on more, like, because all of these tests that we do on them, they're always evolving. We come up with new stains, we come up with new types of testing, and so later on they may look at it and they go, hey, wait a minute, this at that time we couldn't offer this testing, but now we can, because there's like a new genetic test that we can add, or a new immunohistochemistry stain that we can do. So it may not be that they had missed it. It may also be that it just wasn't available at that time.
And thank you. And how long do these samples stay? Would you have them for 20 years?
Yeah. So actually, we have guidelines around how long we can keep tissue, and so current guidelines are that you can keep them up. You can keep like at least tissue from adults at least 10 years, but for pediatric cases, it's even longer. I have a feeling it may change, though, because genetic testing is coming up, especially genetic testing on cancer tissue is becoming more and more important. And I have a feeling that we may end up having to keep that tissue for longer. Like, those guidelines may change. Yeah.
Want to use the microphone?
Yeah, my question is for the lymphoma that expresses the CD20, the follicular lymphoma, is that just on the cancer cells, or do the normal B lymphocytes express that also? And who figured out that you could attack it with the antibody? Like, that's quite complicated.
So that's an excellent question, and yeah, so CD20 is actually expressed not only on the cancer cells, but it is actually expressed on the normal cells too. And so the other thing that I should have mentioned is that, like, when we do the diagnosis, you kind of have to look at it all together. You can't just look at each part individually, and so when we're looking at something like CD20, I look at the CD20, but then I also look at what the tissue looks like, and then I can figure out, yeah, the CD20 that is being expressed on these small cells are actually normal, but the CD20 that's being expressed on the atypical cells these are abnormal. So we kind of look at everything together, and then yeah, so I guess how rituximab was found out. I think, well, it is a long story.
My other question is, so it kills the cancer cells and the healthy cells, the rituximab?
Yeah, so I mean...
and then my question is, if it does that, and patients go on maintenance therapy for 2 years, why don't you continue it, like maybe every year, do a little more just to kill off these cells? I know they're slow growing, but the risk, is there that much risk or cost that you wouldn't want to do it, maybe a treatment every year?
Yeah.
Dr. Curvilla is going to talk about treatment, and I think probably we can save that question till then. He'll probably answer it much better than we could.
We can, yeah, exactly.
I just have a question regarding relapse. Is it recommended to have a fresh diagnosis when there's a relapse?
Often, yes. Yeah, because the disease can change. So often we need to figure out whether it's the same disease that happened before or there's something else going on that's new. So yes, in most times we would need a new tissue diagnosis, yes.
I was just wondering, say you were diagnosed, like you came up with a diagnosis based on the histology, and then you were given treatment, but let's say you didn't react positively to that treatment. Could you possibly like reassess the tissue to make sure, you know what I mean, to maybe change the treatment instead of saying just, you know, this person doesn't react well to the treatment?
Yeah, so I mean, if you, you can always go back to the tissue to see if there are any questions around, you know, why this therapy isn't necessarily working. Yeah, I mean, the tissue is around for a while. Yeah.
Okay, great. Thank you very much. Oh, one
there's
more
one
question. One more.
One more question. What I learned from you is that if I'm going to have this excisional biopsy, it would be worth my while to have a few drinks beforehand because my tissue would be preserved in the wax better.
I think
Sure.
maybe we'll leave it at that. Thank you very much.